Good afternoon, everyone. My name is Christina Sitt. I'm part of the team at Lung Cancer Canada, and welcome to our What's New webinar series. Today, we have a very special webinar that is sharing the highlights of the Canadian Lung Cancer Conference. It was the 21st year of the Canadian Lung Cancer Conference this year, and today on our panel, we have our president, Dr. Paul Wheatley-Price, as well as the co-chair of the Canadian Lung Cancer Conference, Dr. Cheryl Ho, who is also a member of Lung Cancer Canada's Medical Advisory Committee, and then Dr. Justin Gaynor from Massachusetts General Hospital, who also has a very interesting title of Director of Targeted Immunotherapy down there. So I'm going to turn it over to Dr. Paul Wheatley-Price to moderate this session, but with all the questions that you may have, please type them into the Q&A box. We will address them at the end. And unfortunately, please understand that we are not able to address individual medical questions on this webinar, but we will try to speak generally in a generalized what applies to a general population. So over to you, Dr. Wheatley-Price.
Great, thank you, Christina, and hello everyone, wherever you are calling in from across the country, or indeed internationally. This is our fourth episode of this new webinar series that we started in November called What's New in Lung Cancer. And you can go to the Lung Cancer Canada website if you want to look at previous versions of this or previous episodes. We've covered EGFR type lung cancer, ALK lung cancer. Last month, I spoke with Dr. Frances Shepherd from Toronto, and she sort of gazed into her crystal ball of the newest things coming in lung cancer. And next month, watch out for a webinar which will just be talking about immunotherapy in lung cancer, which has really revolutionized what we do in the last few years. So there's some things to look forward to. So what we're going to do for the next 45 minutes or so is I'm going to talk with Dr. Ho and Dr. Gaynor about the Canadian Lung Cancer Conference, which took place about 10 days ago. And it's an annual conference, and Dr. Ho will tell us a bit more about it in a moment. And Dr. Gaynor was the invited plenary speaker. And you saw from the credentials that Christina put up there, Dr. Ho is one of the editors of the Journal of Thoracic Oncology, which is our premier lung cancer academic journal. She's a co-chair of the Canadian Lung Cancer Conference. She is a medical oncologist at BC Cancer in Vancouver. She's a member of the board and the Medical Advisory Committee of Lung Cancer Canada. And I don't know where she has time to join webinars like this. Dr. Gaynor, I imagine, equally busy in Boston as the Director for Thoracic Cancers at Massachusetts General. And you heard there the Director of we get this right, the Targeted Immunotherapy. And I think that's going to be something that we talk about soon. So you don't want to hear me rambling on with introductions, so I'm going to get straight to this. So Dr. Ho or Cheryl, will be informal. What is the Canadian Lung Cancer Conference? What happens?
Thanks, Paul. As Christina mentioned, the Canadian Lung Cancer Conference is a national meeting that we host in Vancouver that we've done so for the past 21 years. Initially started as the Western Lung Conference, but then realized that was an opportunity for us to network across the country with medical oncologists, radiation oncologists, surgeons, respirologists, just I think for an opportunity to share what's going on in our respective communities, also to network about what clinical trial opportunities were and different directions in which we could foster the network across Canada. And the second piece to our conference is also that we host a TLC meeting, which is Training in Lung Cancer. And that is where we invite residents and fellows from across the country to come and do some additional training or focus in lung cancer so that we can foster our next generation of lung cancer specialists. The meeting's generally about 300 people that attend, and we have fabulous international, well-renowned speakers like Dr. Gaynor come and speak at our meeting. And in fact, this year, because of the pandemic, we had to go virtual, and we had over 500 participants. So lots of opportunity to learn at the meeting this year.
Glad you mentioned the TLC bit, and it's been a terrific opportunity for our trainees across the country to go to the meeting, and they hear from the international speakers and the top really lung cancer clinicians and researchers in Canada, and generally free of charge. The conference covers the trainees' expenses,
Yes.
which is helpful when you're a trainee. So this year, maybe Cheryl, I'll just stick with you. Why did you invite Dr. Gaynor to speak? And then we'll ask him what he talked about.
Do you even have to ask why we invited Dr. Gaynor?
We've had great speakers, and I just wondered what is it that you wanted this year, and why did you focus on Dr. Gaynor? Was he the only guy available?
You know, I think that Dr. Gaynor has an incredible reputation in terms of research and development across multiple areas in thinking around treatment for lung cancer, both in the targeted therapy arena, so when we're looking at specific kinds of mistakes that we see in lung cancer and therapies around that, as well as in, as you've mentioned, the immunotherapy arena, where we're thinking about how do we harness the immune system to help treat lung cancer. So there were so many reasons why we thought we could benefit from his expertise. And of course, as he will explain to us shortly, there was a lot to discuss and many new things to share from his research.
So yeah, Justin, apologies for me being a little bit cheeky there. You're welcome, and welcome to the webinar.
Thanks so much for having me. Thanks so much, Dr. O, for the kind words.
The title of your presentation that you gave was Elucidating Mechanisms of Resistance to Novel Therapies in Lung Cancer. So that's quite a lot to unpack. Could we just start off with resistance? And
yeah,
maybe what is resistance, and where does that word come from in cancer?
Yeah, so my background is in developing new drugs, new treatments for lung cancer. And as Cheryl alluded to, you know, we in the last 15 years, there's really been a transformation in how we've treated lung cancer, and it's really arisen because of the development of two big categories of treatment. The first being targeted therapy, which is where you're trying, where you actually take a tumor specimen and you try to do genetic sequencing. That is, you look at the blueprints, you know, the DNA within a tumor specimen, and we recognize that tumors, specifically lung cancer, can have these misspellings, and these misspellings lead to vulnerabilities. And we can exploit those vulnerabilities with targeted therapies. That is, these are pills that block a given vulnerability. And the other major category of treatment that has really revolutionized the treatment of lung cancer has been immunotherapy. That is trying to stimulate one's own immune system instead of recognizing viruses or bacteria or other pathogens, instead actually using the immune system to recognize and attack cancer. Now, one of the challenges in both of these categories is the development of resistance. And I think of that as how cancers can evade those treatments. You know, cancers are smart. And anytime we throw something against them, they have this ability to adapt. And so resistance is really just the systematic way of trying to figure out how cancers are adapting to our current therapies. And for me, I think that's critical because it can inform what we do next. It informs me as a drug developer thinking about, you know, what types of drugs we should use next. And is it a single drug, or do we need some sort of combination strategy? And so my talk was really centered around that approach and examples that we've had over the last couple of years of where we've used our understanding of drug resistance to develop new therapies.
I sometimes think of it as if I try to go home from the hospital, I just jump on the highway. But if there's been an accident or something on the highway, and that my normal route home is not open to me. It's resisting me. I've got to find some other pathway which needs a roadmap.
Mm-hmm. Yeah, I think that's an excellent analogy for it.
So is it inevitable that cancers become resistant to the initial treatments?
That's a great question. I think we could, folks like us, sometimes sit around tables and debate that question. I think it may differ depending on the type of drug we're talking about and which category. I think for targeted therapies, what we've observed is that over time, yes, at some point the cancer will figure out a way around the targeted therapy, but that can take years and years and years and years. With targeted therapy, it's a bit easier to figure out how that resistance emerges. Like what is the biology that underlies that resistance? For immunotherapy, these drugs are newer, right? We've only been using them in lung cancer since 2013. And the power of immunotherapy, I think one of the reasons why there's so much hype around immunotherapy is that there is a subset of people who have these very durable, long-term responses to that treatment. Is it a cure? I don't know. And the immunotherapy, I think, again, there's hype behind it because the most powerful thing about our immune system is this capacity for memory, right? If we think about vaccines were received as a child and other things, we don't receive those every year. I mean, we could talk about flu, and that's a different story because the virus changes each year. But that's incredibly powerful, right? A treatment that you got decades before is still protecting you to this day. And so that's something, that if we can leverage the immune system to make the same durable control against cancer, that's incredibly powerful. And I think that's why there's so much excitement around immunotherapy.
Yeah, I saw some people just in the clinic this morning, somebody on a targeted therapy, crizotinib, has been on it for 5 years, no problems. And somebody who's been on immunotherapy for about 2.5 years now, and there's no sign of any cancer. It's so we're seeing a lot of this. So tell me, and maybe Boston and Mass General is different to other parts in the States where in outside academic centers, or maybe it's not. Maybe you could tell us that too. But how do you find resistance? What do you do if you see somebody in your clinic whose initial treatment doesn't seem to be working? Does that a priori mean that there's resistance, or could even there be other factors as to why a drug's not working anymore?
Yeah, it's a great question. And I think I'll start with the targeted therapy piece because I think that's more straightforward, and then the immunotherapy piece next. So, I think this is evolving. In the last 15 years, there's been a major push in the lung cancer community, rightfully so, to say, even at the time of diagnosis, it's imperative to do gene sequencing, to try to figure out the blueprint of a tumor. And because really, you need that in order to even guide the initial use of a targeted therapy. I tell my patients it's like a lock and a key. You have to have the right lock and use the right key for those drugs to work. And so if you don't test anybody, you have no idea. You're in the dark. So I wish I could tell you today that throughout the world, that rates of doing that gene testing at initial diagnosis were 100%. Unfortunately, they're still not where we want them to be, especially as the science is outpacing sometimes, a lot of our practice sometimes. And so, we now have, I would argue 9 different genetic targets for which we have, either drugs that are approved, depending on the country, or very promising data. And so that's the first step, just even doing that baseline sequencing. So I think for the lung cancer community, I think we've seen tremendous advocacy from both clinicians as patients and families alike, really just championing that need for doing genetic testing at baseline. The question of once someone is on a targeted therapy and then the cancer starts growing again. We started doing this at Mass General back in 2009, 2010, even before we knew what we would find. And I would say at the time it was by no means a standard. We're a research hospital, and so part of our academic mission is to also do those efforts. I would argue that now, in patients progressing on targeted therapy, it has become more standard to try to basically resample the tumor in one of two ways, and look again at the blueprints, look again at the genetics, and see how has it changed.
See which road you need to take to get past the blockage.
Exactly, and you can do that with either a biopsy or now even blood tests.
Okay, and how come blood tests?
Yeah, so the changes that we're looking for are unique to the tumor, right? They're only in the cancer. But we've recognized over the years by actually developing very, very sensitive tools that can detect very small pieces of DNA that have been shed into the bloodstream. Cancers can release some of their contents into the bloodstream, including their own DNA as they're either dying or shedding. And we can, using very sensitive techniques, actually find those genetic changes in the blood. And that's how we can do it using a blood test.
So let me see if I got this right from what you're saying, that really all lung cancer patients, you would argue, should be having this genetic blueprint done at diagnosis, so we know exactly what the right lock and key combination is for the treatment. And then if the cancer starts growing again on that treatment, do the same process again. See if the lock has changed somewhat, if you need a new, and if you can match a new key to it. Is that?
Yeah, I think that summarizes it nicely. The one piece I would add, just for our patients out there, is that unfortunately not every patient will have one of these genetic changes. It's about 30% of our patients will have one of those genetic changes. So unfortunately, that therapy is not right for everybody. But thankfully, we have actually developed very good therapies for people who don't have those alterations. And that's really where the immunotherapy is taking on a very prominent role.
So before we come to immunotherapy, maybe we'll just switch across to the West Coast. And Cheryl, just to put you on the spot here, in Canada, what is access like to this initial testing? Or maybe you could speak for Vancouver at least.
I think Justin's, pointed out some great aspects, and one was how early they started actually testing for resistance, and which is, sort of the discovery piece, right? We need to learn more about what's happening with these types of cancers as they develop resistance to treatment. And of course, we've certainly done that on a discovery basis in Canada. But as you know, Paul, and many of our lung cancer patients that are logged in, a lot of our testing is actually tied to treatment. So because we have this universal healthcare system, if we get a new treatment that has a particular biomarker attached to it, that is packaged together for consideration of government funding. And then if the drug gets approved, then alongside that, the test is also offered, because you actually have to be able to implement or proceed with a program with the right information in hand. And so in BC, we developed a panel to look at multiple genes, and as Justin's pointed out, some of them for which we at that time didn't necessarily have treatment options for, but did it as part of discovery, and eventually we're able to get that as part of practice and funded, so we could identify mutations for which we could offer treatment for our patients. Similarly, and Paul, I think you were part of this program as well, when we were looking at resistance for a specific mutation, EGFR, there was a national group that got together to look at validation across the country for that type of testing. And then when we were able to get osimertinib funded, that testing piece went alongside with that. And then reimbursement was enabled there, where the government agreed that they would pay for the testing. So I think across Canada, the molecular testing has increased, and I think more that we've been moving away from single gene, sort of thinking about panels when the cost effectiveness component was there, in particular because we have funded treatments that we can offer people.
Right. Yeah, that panel being one test which can detect, all 9 maybe of the subtypes that Justin was alluding to, but actually many more than that. Instead of taking a bit of a biopsy to do one test and then a bit more to do another test and a bit more, and then suddenly you've run out of the biopsy. I think that's right, from my experience as well here in Ontario, Cheryl, that molecular testing at diagnosis is pretty good, actually. It's increasingly available to pretty much all lung cancer patients. The big discrepancy is in how quickly you can get it and whether your center does the testing itself, or whether that testing has to be sent out to a different laboratory, which can lead to, in some cases, some delays, which are really unacceptably long. So that's one work in progress, I think, to make that really effective for all Canadians with lung cancer. But maybe we'll come back to Justin here, because one thing that I don't think we do routinely in Canada is do that molecular testing again a second time when a cancer starts to progress in the way that we do a CT scan. We're not doing those additional blood tests or biopsies routinely. But at Mass General, that's pretty standard now, is it?
It's standard for many of the genetic alterations, but not all. Just, sometimes there can be a sometimes in the U.S., even health, our health insurance companies sometimes will push back on that if I can't name what the follow-up test, therapy I want to use is. We've done this as also part of clinical trials and to Dr. Ho's point about investigation and discovery efforts, because in some ways. You need to understand what the landscape of resistance is in order to then guide, what those next treatment and actually build the next treatments.
Right. I mean, maybe I should actually not be too down on Canada, because there is a lot of really cool stuff going on, and we learned about some of that at the conference. Some of the projects going across the country. There's one project that's been done in multiple provinces called the Value Study, which was looking to do the liquid blood test biopsies that you mentioned earlier, Justin, when people are progressing on a targeted therapy. And they've started to find, and have presented this at conferences, they've started to find these resistance mechanisms and being able to match patients to new treatments. So hopefully, work like that will allow this kind of resistance testing to become more standard. There's other projects, one called a Ring project, which took a bunch of laboratories across the country and gave them commercial kits so they could begin to develop their own sort of validated testing, so they can do a lot of this work in-house. And some really cool stuff that I think is more research at the moment, but in Toronto, when people are progressing on some of these targeted therapies, what's happening is they're doing a biopsy, and then they take a few cells from the biopsy and then essentially put it in a culture and grow up a little tumor, a little baby tumor. And they call them patient-derived organoids. Patient-derived because it's coming from the patient's own sample, and then they've got this little sample that they've grown that they can then test new drugs against. And then you find a drug that's effective, feed that information back to the clinician. So this, that's a research project at the moment, but pretty interesting stuff. And So you mentioned, Justin, 30% roughly of people would have one of these targeted groups. We've had some webinars on EGFR and ALK that would be in that category. Next month, we've got the immunotherapy webinar, but maybe you could tell us a bit about resistance and immunotherapy, because that's your title, Director of Targeted Immunotherapy.
Yeah, it's maybe I straddled those two worlds, but targeted and immunotherapy. But yeah, you know, and I just gave a talk on this to our cancer center director last night. You know, one fundamental difference, I think, between targeted therapy and immunotherapy, if we're talking about resistance, is that with targeted therapy, it's almost as good as we get in terms of I hesitate to use the word guarantee, but it's the highest success rate we have in terms of likelihood of tumor shrinkage. If you have one of those genetic alterations and I'm meeting a patient and I prescribe a targeted therapy, that's as close as we get to knowing that, you know, there's a 75% chance that this tumor is going to shrink with the targeted therapy. So most patients will have benefit from treatment, and then resistance can develop. And the medical term we use for that is acquired resistance. That is initial benefit, and then the cancer starts to outsmart our therapy. With immunotherapy, I actually think we're still in our infancy of even developing the right terms. And because right now, I think too many times we just lump it all together. But there's clearly two distinct groups of people. There are some people who start on immunotherapy, and unfortunately the cancer just grows despite the immunotherapy. I view that as, you know, I would characterize that as primary or intrinsic resistance is how I would characterize it. And then there's a distinct group of people who do develop, you know, have a nice benefit, and then the cancer grows. And it's likely that what is driving resistance in those two scenarios is likely going to be different, but between those. Right now they're lumped together for, you know, scientifically, but I think they're distinct. And I think we are now just really trying to uncover what those mechanisms are. If surveying all of the medical literature, there are actually less than 100 cases, not just in lung cancer, any cancer, less than 100 cases that have profiled acquired resistance to immunotherapy. And these drugs are now approved in more than 15 different types of cancers. So clearly we have a long way to go in trying to figure out how cancers can escape the immune system.
Do you think I'm really glad you bring up that distinction between a primary intrinsic resistance, the drug just doesn't work, and the acquired resistance, if it works and then stops. If you had a crystal ball here for immunotherapy, let's start maybe with that acquired resistance to immunotherapy. Are you doing the same sort of biopsies and blood tests when somebody who's on immunotherapy that stops working, or are you thinking about it differently?
No, I think that's a great question, because I think we need to take the same research infrastructure that we've built with targeted therapies and apply it to immunotherapy. Say, even here, it's by no means considered a standard of care to then repeat a biopsy and do all of these things. It's still very much in the discovery phase. But I would argue that the only way we're going to know what should come next is to do those discovery things. And immunotherapy, more than other types of therapies, it's really tricky to figure out new treatments in the lab. And the reason why it's really tricky to figure out in the lab is, you know, many times we're dealing with just cell lines, which is taking tumor cells in a petri dish, or using mouse models. But all of those, even the animal models don't have intact immune systems. You know, the way we get the cancer to grow is by doing it in a model that doesn't have an immune system. So actually figuring out what the best new treatments are in the lab is really tricky for immunotherapy.
Actually, there was maybe, seeing as you mentioned how difficult it is to do that immunotherapy research in the lab, I could just mention one of the other research projects that came up at the Canadian Lung Cancer Conference, which it was a reference to the Montreal group led by a physician, Dr. Bertrand Routy. And they're doing some really interesting work on why immunotherapy is not working, related to what they call the gut microbiome. So the microbiome, we all have a microbiome. It's basically our bowels and what lives normally in our bowels, and all the bacteria that is normal is called the microbiome. It's the normal atmosphere, if you like, the normal flora that lives in our guts. And if that gets interfered with because of a course of antibiotics or something, it impacts the way our bodies deal with immunotherapy. And so, for example, there's some suggestion that antibiotics can reduce the effectiveness of immunotherapy working in lung cancer. So they're doing some really interesting research about trying to restore a normal microbiome and see if that will overcome, I guess either acquired or primary resistance, depending on the situation.
That's a great point. If I may, for 1 minute, give an anecdote on that, which is that, you know, in our old approaches, especially targeted therapy, we're so focused on the tumor, right? But immunotherapy, it's harder because we can't just look at the tumor. We need to look at microbiome. We have to look at the immune cells, right, that are next to the tumor. And I have a distinct memory of, you know, when our folks from one of our collaborating labs on targeted therapy started meeting with one of the immunologists, right? Typically these groups are silos, and the targeted therapy group is explaining to the immunologist of how they're culturing cells, like tumor cells in a petri dish, and just said, oh yeah, we take all the immune cells and we just throw them out, and then just get the tumor cells, you know, just because they're contaminating. And the immunologist like just puts his hands on his head, says, you're doing what? You know, just because in the targeted therapy world, it is very much just the tumor. But now with immunotherapy, you can't just look at the tumor. You actually also need to look what's surrounding it. And that just makes it much harder to figure out what's going on.
Right. That was fascinating. And, you know, I know that, you know, a couple of weeks ago when you gave the presentation, you know, people were really sort of wowed by the insights you had into this. Let me go back over to Cheryl. Cheryl, Dr. Gaynor gave that big presentation at the Lung Cancer Conference, but there were other presenters too, and some that also touched on immunotherapy that we've just been talking about. Could you tell us maybe some of the highlights as you saw them from the conference?
Yeah, I think one of the other speakers, Dr. James Welsh, who is from MD Anderson and a radiation oncologist there, also presented. And the theme of immunotherapy kind of carries through, because this is sort of what's new and exciting, I think, in lung cancer. And he talked about the role of radiotherapy and immunotherapy. And he gave us a little history lesson. He was mentioning that there were competing physicians with their respective thoughts about what was going to be the next best thing in cancer treatment. There was Dr. William Coley, who thought it was going to be about priming the immune system, and what he actually did was slightly different in that he delivered killed bacteria into patients to see if that would help response, and in fact proved to be effective. But there was another physician, Dr. Ewing, who was more thinking that radiotherapy was going to be the answer for treating cancer. And in fact, Dr. Welsh brought those two themes together, saying, well, maybe radiotherapy to some extent is actually can potentially help immunotherapy. And then along the lines of Dr. Gaynor's talk was speaking about resistance. So when a patient is on immunotherapy and develops resistance, is there an opportunity to try to use radiotherapy to help regain that sensitivity to the treatment? So he presented some data or rationale why that might be possible. It may not be feasible for everybody, but thinking about radiotherapy as a mechanism to kill tumor cells, which would enable more of the tumor proteins to be identified by the immune system, how it may change the levels of certain cytokines or signaling proteins in the blood to turn on the immune system as another way. So he presented some research around that, which I thought was really quite interesting as a way of how do we integrate all of the tools that we have and use them to our best advantage in terms of helping control lung cancer in sort of the longer term, and how to optimize our tools. So we have these tools in play, but maybe by joining them together, we can actually do things a little bit more effectively. So that was his focus. And then Dr. Spicer, who is a thoracic surgeon at McGill University, also talked about immunotherapy and the role in surgery, and thinking about opportunities, as we've just talked about, to learn more, in that patients would receive immunotherapy up front and then undergo surgery, and then doing an examination of the tumor that's actually removed to understand a little bit more perhaps about the environment in which it's sitting for those where there was a good response. As Dr. Gaynor points out, we have to look at how the immune system is responding to understand, whether our tools are effective, and looking across the spectrum of patients who had a good response and then those who had less of a response, to maybe understand if there was that environment component that was influencing that. I think also Dr. Spicer reminded us that, we don't always have to look to new tools to improve things for our patients. And he talked about something called prehab or prehabilitation, where he said, if he's thinking about offering surgery to a patient, what is the best way to ensure that they're going to undergo surgery, receive a benefit, and recover quickly from that surgery? And so his proposal, which I think just makes so much sense, and it seems like somewhat silly that we actually had to investigate this in a trial, but he said, maybe what we need to do is actually ensure people's exercise tolerance is better before they have surgery, that their nutritional status was optimized. Can we get people as healthy as possible, even in the weeks preceding surgery? And then saying, this is a really big and stressful time in people's lives. We should also have some psychological support to get through treatment. So, and his study comparing people that had the support in those arenas versus those who had the usual care showed that people actually recovered their functional status more quickly. So I think the two speakers, both in radiation oncology and surgery, kind of remind us about how to use what we have more effectively to do better things for our patients.
Yeah. Thanks, Cheryl. Yeah, I really like the prehab bit as well. And exactly right. It just goes to show that, well, this is a cliche that I sometimes use in the clinic, that care is just as important as treatment in many situations, or sometimes more important. And so, we were learning about the science and resistance and immunotherapies and radiation treatments, but just being fitter going into an operation was great. The other talk that I really liked, if I could take a moment, was Dr. Kazaruni, who's a radiologist at the University of Michigan, and she is involved really as a national leader in the US in the area of lung cancer screening, and the whole idea of trying to diagnose lung cancers at an early stage when they're still curable, and we don't have to worry about resistance mechanisms because the cancer's gone. And screening has been approved and running in the US for not a whole lot of years, but for a few years now. And she described to us the benefits of a national screening registry, and how people who are being screened their information is brought together to a registry to then inform policy to how to improve screening and roll it out further. So one of the issues in Canada we face is equity in access to lung cancer treatments. And so having those kind of programs will really help us to improve our services. Lung cancer screening in Canada is not yet available. British Columbia, where Cheryl is, she would not forgive me if I didn't mention this, but British Columbia is the first province to announce a full lung cancer screening program, which will start next year. Ontario has a pilot program. Other provinces sometimes have a few small pilot programs, and we're really pushing hard at Lung Cancer Canada for our jurisdictions in every province and territory to have access to lung cancer screening. So I really liked her presentation. And
I think also just a comment to our screening is that, you know, it is a combination of the BC government, the Canadian Partnership Against Cancer, and actually our BC Cancer Foundation. They raised 1.75 million to actually enable us to launch it. Because when you think about screening, it seems relatively simple. Somebody would have a CT scan or imaging to identify the cancer, but as with any healthcare system, you have to think about all the downstream effects and how that's actually going to get funded. And so that, I think, is the primary holdback for many of our provinces to be able to launch it. So we were very fortunate that our foundation recognized this as an opportunity for us to do better for lung cancer patients, and so had a big virtual fundraising event for us in the fall that enabled the announcement.
Yeah, and I think the rest of us can look at what you're doing in BC and what Dr. Kazerouni is leading in the US and other jurisdictions. We're going to just do a couple more minutes and then we're going to move to questions. Justin, if I could come back to you, the big elephant in the room, of course, for all of us for the last 12 months has been the pandemic and the lockdown. If we kind of try and tie that to some of the research or work that you're doing at Mass General and back to kind of resistance and testing and biopsying, have you been able to carry on with all of this during the pandemic, or have you had to scale things back?
I think that's a good question to talk about, how sometimes a major stressor like this can force change. And, obviously there have been many changes that are bad, right? This has been a stressful year on many levels. I think, but there are also some changes, within medicine, the practice of medicine. I think back to my practice a year ago now, and I rarely ever did a virtual patient encounter. Maybe once every, I barely, the technology was so clunky, and but this has forced that change, right? And I think that we're not going back, but it also has then pushed us for some of these research efforts to try to use technology to also still get answers. So for example, again, on a research basis, having a mobile phlebotomist, that is someone who actually a nurse who goes to the house and draws blood and does some of these blood tests looking at resistance, in the home. Now, again, not standard, but it's an example of something that would have never happened had it not been for the pandemic. But I think it's teaching us how can we still, because cancer doesn't stop because of the pandemic. And so we need to continue our efforts. We just need to be thoughtful and innovative in how we're going about them.
Thank you for that. Christina has joined us again, which is the sign that it's time for Q&A. Christina, I'll pass this back to you for the next 15 minutes.
Well, thank you to our panelists, and actually thank you to all our participants who are joining us today, because there's been lots of different questions. I'm just going to be mindful that there is 15 minutes left, and so I'm going to ask everybody to keep their answers brief so that we may get to as many of these questions as possible. So we've had questions here spanning really the diagnosis all the way to the actual treatments. And I'm going to direct my first question to Dr. Ho. And because it is about screening, and BC has the honor of being the first province in Canada to have the first screening program. And so some of our participants are listening and asking, you know, I'm not I'm not somebody who smoked, I'm a never smoker. So what about us? When do you think we can get some screening?
I think excellent question. As you rightly point out, Christina, you know, most of the lung cancer screening programs have focused on an older age group and people who have a history of smoking or are current smokers. And that is what our planned rollout will be for the spring of 2020. But, you know, we meet many people that are diagnosed with lung cancer who have never smoked and wouldn't fit those criteria. And so with Dr. Stephen Lamb, Dr. Renelle Myers, and our group of respirologists here, we are looking at different ways in which we might characterize higher risk patients to identify subsets of people who might be more appropriate for screening. And so other investigations that we've looked at is pollution exposure and other aspects around that to see if we can hone it down. But certainly an area for more research, absolutely, so that we can help all of the lung cancer community.
Perfect. So it's something that's an active area of research, is that patients that don't qualify now have not been forgotten, and we will continue to work on it until we can identify everybody that's been at risk for lung cancer, not just those at highest risk.
Christina, maybe we should give a shout out to the first Lung Cancer Canada, or the biggest Lung Cancer Canada research grant that we gave to Dr. Myers, who Dr. Ho just mentioned, studying breathomics for early detection, so the chemical composition of exhale breath. So if you're on the line, and this is a shameless call, but if you want to donate to Lung Cancer Canada, we can. we're funding research projects like that.
Thank you, Dr. Wigley-Price. I'm going to go over to the East Coast, and I'm going to direct the next question over to Dr. Gaynor. There's been a lot of questions, Dr. Gaynor, that have been submitted to us about immunotherapy and how and its role in those with targets. When do you give it? Do you give it before the targeted therapy? Do you give it after the targeted therapy? What is the success rate, and what has been what is the approach that you think might be upcoming?
Great question. I'll try to answer it briefly, although we could spend an hour on this one question. I think the way I think about it is that lung cancers with those targets are almost like a fundamentally different form of lung cancer. So, one of the predictors of how whether immunotherapy is going to work is whether there is something for the immune system to recognize on the tumor. Is there something that's different about the cancer that distinguishes the cancer from everything else? And the more mutations in a tumor, that is, the more misspellings, the more the tumor looks different than the rest of your body. So cancers that have these targets, those tend to be the only targets in the tumor, the only mutations. They tend not to have a lot of other changes. And so they look very, 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 very close to normal. And so what we found is that immunotherapies really haven't been successful in those groups of patients. That is, the likelihood of tumor shrinkage is just simply lower. And for us, the concern is that the mix of immunotherapy with targeted therapy, they don't mix well. That is, we see more toxicity with a combination of the two.
So it appears that those with targeted therapies at this moment, with the tools that we've got, do better on the targeted therapies, but this is something that's an active area of research and we just need more understanding in this area.
Yeah, so I would always prioritize targeted therapy for those patients. And we have ongoing studies looking at the role of immunotherapy for distinct patient populations.
Perfect. And I'm going to ask Dr. Wheatley Price, our president, to put on his medical oncologist hat now and answer one of the questions. There's been a lot of questions also about biopsies. So how accurate is liquid biopsy? Can it ever replace the tissue biopsy? And if when should it be done?
You know, I might co-opt Dr. Gaynor to answer that with me, because he really is more of an expert than this in this than I am. But I think you heard him say that, particularly for people on targeted therapies, when there is progression, then we like to get a better understanding of the new genetic fingerprint of the cancer. And you can do that in these two ways. You can either do a tissue biopsy, or you can do a blood test. The problem is neither one of them is 100% accurate. And the other thing is they don't entirely overlap. So it's a bit like a Venn diagram, that if you find something in a tissue biopsy, you'll probably find it still in the blood test, but you may not. And if you don't find it in the tissue biopsy, you might find it in the blood test, but you may not. So some cancers don't shed their DNA as well into the blood. So you might not pick something up that truly is there. And conversely, some of the biopsies themselves, when you take the tissue sample, and Dr. Gaynor mentioned this as well, you know, that his immunologists were shocked when they discarded all of the other stuff to find the cancer cells, but sometimes there's a whole lot of other stuff, dead cells, and there's not much actually live cancer to test in the sample. So there are challenges with both tissue and blood tests, that they're not entirely concordant, and neither of them are 100% accurate. So I'm not sure that entirely answers your question. I mean, I think when we get to a future state, we'll be reliant more on the blood test as a routine test, because it's easy and safe and quick. But I don't know, Justin, do you want to add something to that?
Yeah, I would just add, I agree with that. I view them as complementary. You know, I think that's getting to your point that they can provide different pieces of information. They each have advantages and disadvantages. Sometimes you just don't have enough tissue from a biopsy, or you've exhausted it. And that's one scenario where the liquid biopsy can be helpful. But only about 70% of tumors actually shed DNA into the bloodstream. So if you don't find something on the blood test, it's not to say that it's not there. So if you find something, it's helpful. If you don't find anything, it's like a non-diagnostic test. It's not negative.
And we should mention, Christina, for the Canadian context, that these blood tests are they're either a research tool or you pay for them privately. And there are a couple of very good commercial providers of these services, but and there's a Canadian company actually based in British Columbia, which is doing this as well, but they're not all the same. They don't all test exactly the same things, and the cost is generally a four-figure bill. They're not cheap. They're often thousands of dollars. So a lot of the research that actually was highlighted in this area at the Canadian Lung Cancer Conferences is in trying to validate new and effective ways of doing these tests that make them affordable and accessible.
So for our patients that are listening out there, one of the questions you should be asking if you do go for one of these tests perhaps can be what biomarkers are being tested, and how many mutations is in the test that you're getting.
Right. So maybe just a very, very quick example. I saw a young man last week. So he's a young man, he's my age. So young man, never smoked cigarettes in his life and has been diagnosed with lung cancer. And we had done some the molecular testing to look for these genetic subtypes. at our own lab, and we didn't find any, but we don't test routinely for all of them. We just test, as Dr. Ho mentioned, the ones where we've got an available treatment. But there's a reasonably good chance that he'll have one of the other ones, these subtypes, and Dr. Gaynor mentioned 9 that you feel there's treatments for, and we really test for 5 of them. So I was explaining to him that, it would be ideal if we could do further testing, and then so he left, and he's not a wealthy man, and the test that one of the test options would be about 6,700 Canadian dollars with the exchange rate. So we've been working around, and actually we're going to try and utilize a research program that actually was also highlighted at the Canadian Lung Cancer meeting, called Octane, which is an Ontario initiative, which is just coming to an end. So we're going to sort of squeak him in to get this testing. So I think to your point, Christina, people should ask their oncologist, what molecular testing is available to them. Are there research protocols that they could enroll in, which would get this information for them and for their clinicians? And if they've got insurance or deeper pockets, then there are these private pay options.
So we've got a few minutes left in the webinar, and I'm going to turn my second last question back to the CLCCO and direct it to Dr. Ho. At the times when I've had the fortune of attending the CLCCO, one of the things that really strike me is the community feel of the conference, and how nurses, residents, trainees, and radiation oncologists really are all encompassing. And I noticed that you find a couple of ways to honor those who've really contributed to the Canadian landscape of lung cancer. I'm wondering if you can comment on that and tell the audience a little bit about that.
Thanks, Christina. You're absolutely right. It is a relatively small community across Canada that focuses on lung cancer treatment. And at the Canadian Lung Cancer Conference, we take an opportunity to recognize our peers that have contributed to research, to mentorship and advocacy through the Lifetime Achievement Award. And so this year it went to Dr. Vera Hirsch, who is a medical oncologist at McGill University in Montreal. And she actually has a career that has spanned decades and contributed to a lot of the early work with EGFR and ALK clinical trials. So those are targeted therapy options. And even one of our other speakers referenced the fact that she had just enrolled another patient in a surgical trial looking at a neoadjuvant or immunotherapy before surgery. So her contribution to our knowledge base across Canada, her mentorship of the many medical oncologists that now are focusing on lung cancer was something that we took an opportunity to recognize at the meeting this year.
And then I noticed there's also something called the Betty Rice Award.
And thank you. Of course, we also have the Betty Rice Award, which is an award from the Rice family because their their family member had passed away from lung cancer. And that is an opportunity for us to recognize some of the trainees that are involved in lung cancer research. And so our award this year were Dr. Sally Lau, who's currently at Princess Margaret Hospital, but is actually at BC Cancer for her medical oncology training, and then Dr. Katie Jasper, who is a radiation oncology trainee at BC Cancer as well. So opportunities to foster future lung-focused oncologists.
Perfect, thank you. And the generosity of families who have lost loved ones to honor the memory of their loved ones have really contributed to the Canadian lung cancer landscape, such as the Rice family, as well as the Ogram family, which Dr. Wheatley Price mentioned before. So before I close out this webinar, I just want to touch on something that we've been, Lung Cancer Canada, we've been getting a lot of different questions on in the last few weeks and the last few months. And is that question of vaccines in relation to lung cancer patients. Are lung cancer patients eligible? When will lung cancer patients be vaccinated? And I'm going to turn that most difficult question over to our president, Dr. Wheatley Price.
Yeah, thank you, Christina. sure all of us are a little anxious about the vaccine and issues around it, and particularly as we watch other countries seem to more effectively vaccinate their populations than we're able to do in Canada at the moment. I think the bottom line is that a lot of the vaccine trials did not include lung cancer patients or generally cancer patients at all. So we don't have tremendous data to say one way or the other. However, we do know a lot about the types of vaccines. We do know a lot about their general safety. We do know a lot about giving other kinds of vaccines to cancer patients. So I think almost universally, the healthcare professional side of lung cancer is confident that we should be all getting vaccinated, and lung cancer patients are at higher risk of complications from COVID, so should also be getting vaccinated. Now, that's where it gets an easy thing to say. There, of course, there are going to be individual cases where it's a little different, so check with your team. The other issues, of course, now is, well, when is that going to happen? And are lung cancer patients going to be prioritized ahead of other members of the general public? And that's something that we don't know yet. These policies are still being developed. So we don't know in each jurisdiction, are the cancer centers going to be offering the vaccine to cancer patients, or is it going to be in vaccination hubs? We don't know that. So I would please ask you to pay attention to that. At Lung Cancer Canada, we're trying to advocate for lung cancer patients to be offered the vaccine sooner, and really watch out for that. But unless you've got a very good reason when you are offered the vaccine, you should take it, and just check with your team if you're on treatment like immunotherapy or chemotherapy or a targeted treatment, or radiation, or you're coming up for an operation. Just check with your team if there's an optimal timing to get the vaccine.
Thank you for that, Dr. Wheatley-Price. And Lung Cancer Canada is putting together a special section on our website that tries to collate all the provincial plans as they become available. So please take a look out for that. And on that note, I just want to thank all of our panelists who are at the 2 o'clock hour for this webinar. Dr. Gaynor out in Massachusetts, Dr. Ho out in BC, and our moderator, Dr. Wheatley-Price in Ottawa for this webinar. And if you enjoyed this webinar, I encourage you all to sign up for our next webinar, which will be happening at the end of March, and that's featuring what's new in immunotherapy, featuring Dr. Roz Jurgens from as our chair of our medical advisory committee, as well as Dr. Julie Bramer from Johns Hopkins University. And with that, we close out this webinar, and thank you all for participating. Thank you all for sharing your day with us, and we wish you a wonderful rest of the afternoon. Thank you.